when bylines, the early signs of congestion, appear in your patients. And finally, the last very advanced application is the study of anesthesia-induced atelectasis. You know that this is a problem in our patients, not only in adult patients, but also in pediatric patients. The numbers are very high. And this is the example of what happens in our patients, examples of anesthesia-induced atelectasis. So what is the potential of lung ultrasound? The potential is that lung ultrasound is more sensitive than chest radiography, for example, and not so sensitive, of course, like CAT scan, but we cannot use CAT scan in our patients. So the only way we have to assess this kind of conditions in the lung during the operative scenarios is to use lung ultrasound. And not only to use lung ultrasound to assess the condition of the patient, but also to assess the change that we can obtain by changing our ventilatory strategy. This is an example of what happens in tidal recruitment and after recruitment maneuvers. So we can assess the difference in a stable recruitment obtained by maneuvers. So what we can do is to change our ventilatory strategy to obtain recruitment, and then the same to titrate the correct ventilatory strategy to obtain the minimum level of recruitment that is the safest level for our patients.
2 minutes.
Thank you for your attention.
We'll take a question for Dr. Barrett, and you may go to a break. 10 minutes, please. We're trying to catch up. We're behind schedule, so the 5 minutes break. Okay, 5 minutes discussion and 10 minutes break. So should we call the Dr. Boker back and did Dr. Michael Allison leave? Ah, good.
Just a question regarding the ECMO. For a secondary hospital that doesn't have a cardiac facility, and we face patients which fits the criteria, maybe your criteria for lactate and their clinical setup. We face them maybe once every 2 weeks, once every 3 weeks. What's your advice for us? We really like to endeavor into that project.
Working. I think you've got to look at this as a systems issue. So either within your health system, you decide that ECPR will be done in one institution, in which case you all agree that that institution will take a certain category of cardiac arrest, in which case that institution puts in place the resources to achieve this. Or, on a system level, you decide to have multiple hospitals providing it, in which case you're going to have to look at volume, training, access. In short, if you want to do this, you've got to be trained to do it. You've got to have the infrastructure there, and this is a 24/7 infrastructure. So you've got to have somebody available within 10 minutes, 24 hours a day, in order to place the cannulae. Now, the solutions in my hospital are not going to be necessarily the same solutions in your hospital, and the solutions in my healthcare system aren't going to be the same in yours. So, unfortunately, there's not a really simple answer, because you've got to look at the system-wide approach. How many cardiac arrests do you have? What are you going to do with these patients downstream? Are you in a position to be able to withdraw at day 3, 4 or 5, as I am, for patients who have significant neurological injury? Yeah. So for us, we have intensivist cannulate, We have perfusionists there at the onset of ECMO. So the perfusionists prime the pump, they're there for commencement, they're there for mobilization of patients, etc. But the nurses run the pumps on their own, minute to minute, with oversight from the intensive care consultant. But the nurses do it all.
Huda, do you have
Yes. Thank you very much for brilliant lectures, really, from the three speakers. I really enjoyed this session very much. I've got several questions, but I know there's people in the queue. But I'll start with Dr. Boker regarding simulation versus in situ training. I really like the video you showed, and it really shows what the problems are with the in situ simulation training. And I remember being involved in a similar situation. It wasn't as disastrous as that, but we were running like a scenario in the maternity hospital, and we ran the scenario, and we just did things as usual. And you tend to kind of tell people in advance, certain people, that you're going to do simulation scenario, so that you don't get a panic and you don't get all the disasters like you illustrated in the video. But we forgot to tell the pediatricians. So when we ran the scenario and the emergency drill went, the pediatricians all came down thinking it was a disaster, but it wasn't, and they were actually involved with the patient, and they had to one of them had to leave them, and they were really upset that we did it and we didn't inform them in advance. But at the same time, you want to test the system, as you said, to see whether it's working and whether people will respond to you, so you don't want to tell them in advance. So how do you manage this challenge, between trying to do it in real life situation and at the same time to be safe?
I think this is very important, and I think to work from bottom up and top down, the way that we do it, we really have everybody informed ahead of time. We have everybody informed ahead of time through circulating memos to departments and chairmen. And we always get the hospital administration involved early on. So everybody in these clinical situations know that there will be mock drills. We had this resistance because if people are not signing in, if the administration is not signing in, it will be a big problem. But now, even at the Ministry of Health, not only university hospital or National Guard or military hospital, even Ministry of Health hospitals, and even at temporary location in Hajj, it's becoming routine that the days leading to Hajj, before a pilgrimage arrive, all hospitals in Mecca, Mina, Arafat, Muzdalifah, all go through simulation in situ before pilgrimage come. So it takes time, but communication, written meetings, preparing everybody, but it's essential to test the system. You just can't do everything in the simulation center and expect people to transfer this back. So you need to make the connection, and the more experience you have, the more things in the system you will find, you will fix it the next time.
Thank you very much. Salah again, please. We're going to take questions for 5 minutes more, and anybody who wants to leave for a break, please come back in 10 minutes. Thank you. Salah, did you another question? Okay, go ahead, please.
My question is for Dr. Allison. You talked about a great approach for the penetrating trauma. I want to know what do you think about the other end of the spectrum, the non-penetrating ones, how to approach it, when to suspect it, and when it is safe to say that this patient, he might go home or he gets admitted or he goes to the OT. Thank you.
That's a great question, and let me just repeat it, is what about the blunt trauma patient, the blunt chest trauma patient? What are we doing for these patients? And I think that my answer today is probably going to be different than what you're doing in a year and maybe even 5 years, because the literature is actually changing on that. And that's the use of early echocardiography and high sensitivity troponin in evaluating these patients that are coming in. First, on the high sensitivity troponin use in blunt cardiac injury, I think the data right now is in the middle. I don't think there's clear-cut evidence that you are going to be able to screen effectively with, I think you're going to be overly sensitive in seeing patients and keeping them in the hospital and not discharging patients that potentially can go. But you probably know that there are case reports of all of these delayed injuries from cardiac contusions and cardiac trauma, so you don't want to miss those patients and send them home and have a cardiac event. So what I've seen in looking through the literature is that a lot of centers are including point-of-care troponin into the evaluation of these patients, and if it is positive, they'll keep them for observation up to 24 hours. There are some centers that have not adopted point-of-care troponin, but I think it's going to become more common, and I think within a couple years' time, it's probably going to be universal. The guidelines right now just suggest that if you have blunt cardiac trauma, the only thing you need to do is do an EKG to look for dysrhythmia. So that's the guidelines as they currently stand, but I think guidelines are going to change.
Final question from Hussein, please.
Yeah, Dr. Nicholas, thank you for this presentation. You did mention following 10 minutes of CPR, you should consider ECMO. That will be a lot of time wasted then really to activate the system, because as you said, it's not about a machine, it's about a system, about a team, which a lot of hard work, a lot of time will be wasted. Wouldn't it be like within 1 or 2 minutes, really you should activate the system and wait for 10 minutes to actually initiate it then?
So it depends very much on what your system looks like. We wait until the 10-minute mark in order to activate, on the basis that we can then muster quickly and then commence ECMO, because commencing ECMO takes 20 to 30 minutes. It's more about selecting the patients. So if you've got 10 minutes of CPR, many patients will have already gotten ROSC, or you'll know what their age is, or you'll know a little bit more about them. So it's trying to not continually activate the resource. But you're right, in some systems, they keep the team virtually permanently available within the emergency department because they have so many cardiac arrests. And the Taiwanese do that. And so they have a standing eCPR team, so they do it permanently. We don't have a standing eCPR team that's just waiting, purely people allocated to do nothing else other than do eCPR. So we wait until the 10-minute mark. Those that clearly have got ROSC, we don't have to worry about. We've often know a little bit more about the patient by the 10 minutes and choose not to activate. And then you've got a smaller group of patients that you choose to activate, knowing that you can then get the team down and get them on within the next 20 minutes or so.
Thank you very much. Just a small comment. I met with Richard Jonas, the pediatric cardiac surgeon from Harvard, about 12 or 14 years ago. And they had instituted the ECMO program in their practice. And they said whenever, cardiac arrest happen, while we're resuscitating, we look for reasons, not to put, a patient on ECMO, meaning that everybody goes on ECMO, and without delay. But of course, they have a, very fast intervention, and just a small comment. Thank you.
Sorry. We're going to start the next session in 10 minutes. The next session 10 minutes later than usual. So 10 past 10 for the next session, just to overcome the delay. Yeah. So 10 past 10, next session starting. Thank you.
Thank you.
Oh, hang on.
I thank our guest speakers. And
well, we would like before, sorry, Dr. Imad, before we finish, Dr. Abdulaziz Bokar is going to leave us today. Unfortunately, he's got another meeting to catch, so I'll just have to come up to the stage. We'd like to thank him for coming here to Kuwait and being with us and giving us the 2 brilliant lectures really on simulation. We really enjoyed them, and we enjoyed your presence and your experience and your comments and feedback on our first simulation session that was conducted yesterday. So that was really great to have you here, and thank you very much for being with us. We'd like just to hand you.